Good morning, good afternoon, and good evening. My name is Caroline Moreau, and I'm really delighted to introduce this virtual ICFP session on innovations in research in response to the COVID-19 pandemic. We gather today at a difficult time as the second wave of COVID-19 is raging in many parts of the world, bringing its toll of fear and mourning to many families. And so in this context, our work as public health researchers, practitioners, and advocates has found more immediate relevancy as we seek to understand and respond to the health and social implications of the pandemic on a global scale. The epidemiology, response, and impact of the pandemic has varied widely across the world. Each presentation today showcases an innovative research response utilized to understand the diverse impacts of the COVID-19 pandemic on family planning and reproductive health. I will now take a few minutes to welcome our Francophone audience before I introduce our four esteemed colleagues who will be discussing their work.
The second wave of the pandemic is ravaging the world, and in this context, our work as public health researchers, practitioners, and advocates is more relevant than ever, and is today leading us to understand and respond to the health challenges that are linked to the pandemic. The responses and impact the pandemic has varied greatly right over the world. And here we'll have some examples from East Africa, West Africa, and in Northern Asia. Each expert will show us some innovative research, also about the practices in family planning.
Sur les pratiques en matière de planning familial et sur la santé reproductive. So let me turn first and introduce Dr. Kangwana, who will be discussing the effects of COVID-19 on sexual and reproductive health and rights of adolescents in Kenya. So Dr. Kangwana is an epidemiologist with several years working in public health research, both in developing and developing country settings. And she currently works as a senior program officer at the Pop Council in Kenya and is the principal investigator for a study testing how to improve access to community mental health services in urban informal settlements in Kenya. She's also co-investigator on a number of studies evaluating ways to improve adolescent health and well-being in developing countries. Before she joined the council, Dr. Kangwana worked as a research associate at the Imperial College of London and at the Center for Infection Prevention and Management, and at the Kenya Medical Research Institute Wellcome Trust Research Program. She holds a PhD in public health from the Open University in collaboration with the Kenya Medical Research Institute Wellcome Trust Research Program, as well as a master's in global health sciences from the University of Oxford. She has a master's degree in pharmacy and is a registered member of the Pharmaceutical Society of Great Britain.
Our second presenter, Lambert Chalachala, will talk about the innovation that were started in DRC in order to remedy the difficulty of access to family planning. Dr. Lambert is a doctor in medicine from the University of Kisangani in DRC. He's also a specialist in public health after he got his master in maternity and youth health from the University of North Carolina in the United States. He has over nearly 20 years of field experience in the management and evaluation of projects for HIV and also sexual violence. and an emergency situation of epidemics such as Ebola. He also led and took part in various studies and operational research in DRC and Ivory Coast. After working for the government, Dr. Jean Lambert worked for Doctors Without Borders, Doctors of the World, and and the public health school from Kinshasa. For the last 5 years, he's worked as a research collaborators at the Carolina Population Center at the University of North Carolina. He's based now in Kinshasa, and he is a representant in DRC for the Family Planning Country Action Process Evaluation, which is an evaluation project to study investment portfolio from the foundation, the Bill and Melinda Gates Foundation in Nigeria and DRC. And as a Rotary Peace Fellow, is also a peace ambassador.
Let me turn to our third presenter, Dr. Laura Lindberg, who will be presenting on understanding the impact of COVID-19 on sexual reproductive health in the United States. She's a principal research scientist at the Guttmacher Institute, and as a social demographer, Dr. Lindberg focuses on measuring trends, determinants, and consequences of sexual and reproductive health in the US, particularly regarding the needs and behaviors of adolescents, and working to improve the quality of survey data and SRH behaviors. Over the course of her career, she has conducted policy-related research on adolescent sexual behaviors, sex education, adolescent preventive services, unintended pregnancy, and contraceptive use. She's currently principal investigator of an NIH funding research related to improving the measurement of abortion and US surveys. She leads and contributes to the designing, fielding, and analysis of multiple surveys, including a national survey to assess the impact of COVID-19 pandemic on women's fertility preferences and access to SRH services. Dr. Lindberg has published in many top peer-reviewed journals in the field, including Demography, Studies in Family Planning, American Journal of Public Health, as well as Perspectives on Sexual and Reproductive Health. And additionally, she plays a major role at Guttmacher in providing expertise on SRH health topics to the media. She received her undergrad degree from Princeton University and earned her MA and PhD in sociology at the University of Michigan. Finally, but not least, Dr. Vinit Sharma will be presenting on modeling possible scenarios of the pandemic's effect on family planning and fertility in the region and responses from the national programs. Dr. Sharma is a passionate advocate for the health of women, young people, and disadvantaged population. He's an award-winning expert and is a respected thought leader with nearly 3 decades of technical experience of working in multicultural environments and leading teams in the UN agencies, academic, and research institution. His main competencies include leadership, policy, advocacy, rights-based programming, strategic communication, forging strategic partnerships, and resource management. His technical expertise spans from adolescent health, maternal, newborn, and child health, family planning, human nutrition, health management, including health system strengthening as a disease surveillance and eradication. He has a postgraduate training in adolescent health and sexuality from the University of Lausanne. He has lived, traveled, or worked in more than 50 countries around the world in complex and insecure environments as well. And last but not least, he's recognized as a good team player. So let me turn the mic and welcome everybody and turn the mic to Dr. Kangwana. Thank you very much.
Hello, everyone. I shall be presenting on the effects of COVID-19 on sexual and reproductive health and rights of adolescents in Kenya. My name is Beth Kangwana, and I'm presenting on behalf of a team from the Population Council's Poverty, Gender and Youth program. The study was a collaboration between the Executive Office of the President and Population Council. The overall objectives for this presentation are to present findings from phone interviews on the effects of COVID-19 on sexual and reproductive health and rights in Kenyan adolescents. We then use qualitative findings to understand the effects observed from the quantitative findings. We shall be using these data to inform COVID-19 adolescent programming and policy in Kenya. From the quantitative data collection, we collected data from cohorts that were already established from previous studies. Data was collected from around 4,000 adolescent boys and girls across 4 counties. Adolescents were between the ages of 10 to 19 years old. So the areas or the counties that we looked at was Wajir County, which was in the northeastern part of Kenya. We managed to interview just over 1,000 adolescents, boys and girls, in July last year. We also went to Kilifi County, which is at the coast of Kenya. We interviewed around 600 adolescents in August. In Nairobi County, we interviewed just over 1,000 adolescents in June last year. And Kisumu County, which is in the Lake region, we were able to interview just over 1,000 adolescents in August. The topics covered for the quantitative data collection were on COVID-19 knowledge, attitudes, and practices. We also looked at the effects of COVID on, as I said, sexual and reproductive health, but this was only in adolescents 15 years and above. We looked at the impact of COVID on violence, on other aspects of health, education, and social interactions. These were structured phone interviews that took around 45 minutes each and were carried out in the local dialect. Preliminary analyses was carried out and consisted of percentages calculated per study site. Selection bias was likely to be a limiting factor since we were only able to interview those who had access to a phone. We were able to carry out 174 qualitative interviews on adolescent girls, including those who were pregnant or already had children, boys, their parents, and key informants. We carried out these interviews in November of last year, and the purpose of the interviews was to provide some context to the quantitative findings. The interviews were carried out in person, however, we implemented COVID-19 mitigation measures. The in-depth interviews were recorded with participant permission and transcribed directly into English. Transcripts were then validated and reviewed for quality assurance, and coding took place on Atlas TI, where themes and sub-themes were identified. A pre-selected number of participants were double-coded to ensure internal validity. In the results, we will cover the effects of COVID-19 on access to healthcare services and general health, on violence, pregnancy, early marriage, and family planning, and female genital mutilation. So we'll start off with access to healthcare services and general health. From the quantitative data, we saw that around 10% of adolescents were likely to skip healthcare in all sites apart from Wajir. Girls were more likely to skip healthcare compared to boys. The main reason for skipping care was cost, followed by either lack of services, medicines, or fear of COVID-19 infection. The data also showed that adolescents were 2.5 times more likely to skip necessary health services if their adult head of the household had lost their full income. Among menstruating girls, over half of menstruating girls had trouble getting menstrual hygiene management products since the COVID-19 pandemic started. This was in all the counties apart from in Wajir, where around 1/3 of girls reported poor access to MHM products. And the reason for this lack of access was due to lack of financial resources to purchase the products. Next slide, please. There was also a food security crisis. With the exception of Wajir County, around 70% of household heads and close to 80% of adolescents reported skipping meals or eating less in the past 2 weeks due to COVID-19. This was higher in urban compared to rural areas. From the qualitative findings on general health, interestingly, adolescents reported that adhering to COVID-19 prevention measures had contributed to a measure to increased general health for adolescents. And one quote from an adolescent who said that my health has improved because right now you will find that many people are maintaining social distance, and that prevents you from contracting other diseases like TB. You find people have face masks, people are sanitizing, so it has prevented us from other diseases like cholera, diarrhea, cough, TB, and many others. However, some adolescents reported that a lack of money for a proper diet compromised their health and nutrition. And one adolescent said that my health was affected by lack of enough food since we were only eating twice a day. We, includes the siblings, are now weak. Similar to the quantitative findings, lack of money to pay for services limited their ability to access healthcare services. Due to financial challenges, purchasing of food took priority over healthcare. Another quote from a stakeholder says that because there is no money and the amount of money they get in the family, it is used to buy food. When it comes for money to go to the hospital, it is not available. Such a person is affected and has to wait for money to be available. Other barriers mentioned to accessing healthcare included lack of medication, lack of health personnel some of them were on strike during that period, during the COVID pandemic, and also movement and time restrictions due to the curfew. Some adolescents reported that the fear of getting a COVID test and it being positive held them back from seeking treatment from a health facility. Another quote from an adolescent said that there is a day I had chest pains. I was coughing and I also had a cough. And I could see that in the television, those are the symptoms of coronavirus. So I was afraid to go to the hospital because maybe if I could have gone to the hospital, they could have diagnosed me with corona, and maybe it was not corona. And it will involve a lot of expenses to get the treatment. There was also a fear of contracting the disease if they visited the health facility. We'll now go on to look at the impact of COVID-19 on violence. From the quantitative data, adolescents reported experiencing increased tension of violence. This included emotional, physical, or sexual violence at home. This was highest in Nairobi and Kisumu counties, where around 1/4 reported increased tension. Far fewer adolescents reported increased violence. Emotional violence was experienced more than physical and sexual violence. For all reports of violence, 1/2 to 3/4 said it was happening more than pre-COVID times. Majority of those who were reporting sexual abuse were girls. From the qualitative survey, reasons given for the rise in violence was as a result of an increase in crime, conflict, domestic violence in the community during the COVID period due to loss of jobs and idle youth. Some adolescents developing aggressive behavior as a result of domestic violence and conflict experienced at home during the COVID-19 period. And one quote from the parent, just to highlight this, said that during this time, during the COVID-19 pandemic, there is a lot of conflict because there is no money. Then the children see the conflict. The children are also bitter. They bring it out. So they see you having something, they can come and steal. You joke around with them, they will beat you up because they are already angry. Life is so unfair on them. From the quantitative data, we saw very low rates of pregnancy or child marriage so far. So around 1% of girls in the sample were either pregnant or married since COVID-19 had started. When it came to family planning, in Nairobi, Kilifi, and Kisumu County, over 90% of adolescent girls reported not wanting to be pregnant and not being sexually active. We also saw low use of contraceptives, so less than 1/3 of all adolescents were using contraceptives. And we did not ask about family planning use in adolescents residing in Wajir, since this was a culturally sensitive topic. However, we have seen that the risk factors for early pregnancy and marriage have been exacerbated due to the pandemic, and we've seen these risk factors have increased, such as economic stress and low use of contraceptives. The qualitative findings further highlight the impact of COVID-19 on exacerbating adolescent pregnancy risk factors. Many adolescents mentioned increased sex for money or pads, especially with within the COVID-19 pandemic, where we see poorer access to mental health hygiene, menstrual hygiene management products. Respondents also mentioned idleness and increased boy-girl relationships have also resulted in pregnancies, and lack of free family planning provisions in the health facilities during the COVID-19 period. And another quote from an adolescent in Nairobi who said that during the Corona period, I went for the first time and they told me that the family planning method I want is not available. I went to the second time and they gave me an option, not the one that I wanted, that they don't have the one that I want and I should instead take a different one. In addition, the quantitative findings highlight the impact of COVID-19 on exacerbating adolescents' early marriage risk factors, such as violence at home, pregnancy, financial challenges, which push girls to early marriage. Some girls plan to enter early marriage as a strategy of creating an avenue for financial support. And we see this from a comment from an adolescent girl in Wajir who said, there are these girls who married out of their own volition because they heard that since the schools were closed for a very long time, about 6 or 7 months, the students will have to repeat a class to catch up on what they had lost. And therefore, to them, that is a waste of time. Hence, the alternative is to get married. Finally, looking at female genital mutilation, mainly, this was practiced in Wajir County in the northeastern part of Kenya. And from the qualitative findings, we learned that adolescents attest to FGM secret practices, while parents and stakeholders deny its existence. And we also see that COVID-19 has had no major influence on this practice. This was what we learned from the qualitative findings. So thank you. That's the end of my presentation, and I'm happy to address any questions or comments.
Good morning. I'm going to get starting. My name is Lambert Chalachala, and I work with the University of South Carolina. And I will present a summary of the quick evaluation of the COVID-19 pandemic effects on the investment portfolio for family planning of the Bill and Melinda Gates Foundations in the Democratic Republic of Congo. We've done this work together with several different stakeholders. Next slide, please. So here is the agenda for today. I will start with an overview of the FP CAPE and the portfolio for family planning on the Bill and Melinda Gates Foundation. Then I will talk a little bit about the rapid assessment methodology that we've been applying and what the situation with COVID-19 is in the Democratic Republic of Congo. Then I will show you a sample of qualitative results and the quantitative results as well. And then we will talk about the conclusion that we've reached. Next, please. So, what is the objective of FP CAPE? This project is a project of the North Carolina, University of North Carolina, as I've mentioned before. And what we want to see is how the investment portfolio for family planning is used in Congo and Nigeria in order to reach the goals, the national goals, in case of the contraceptive measurement that we've been used. FP CAPE gives rise to evidence to see how and why each mechanism that is implemented can actually bring about a long-term change, a lasting change. So the evaluation that took place takes place at level of the portfolio. We don't have individual portfolios, but we are trying to see what are the synergies that are being implemented between the different programs so that we have a common goal. And this work is done prospectively in order to allow the different projects to have access to our results and to be able to adapt their activities based on the exchange of information. Next, here in the Democratic Republic of Congo, you can see that the investment portfolio that we have about a different product, about a dozen different products where we use in each of the different intervention areas. Next, please. And now we are going to talk a little bit about the rapid assessment methodology that I have mentioned before. Next, please. So, in the Democratic Republic of Congo, the first COVID-19 case was detected on March 10th in 2020. A week later, the government was kind of reactive and implemented different measures, for example, border closures, school and university closures, in order to limit the spread of the pandemic that had actually started only in Kinshasa. 2 months later, as of June, with when the pandemic seemed to be under control, so they started to ease the restriction measures, and the restrictions were removed in August. But with the second wave, where we found several positive cases as of December, the government implemented new restrictions, for example, curfews, school closures as of December 15th. So up to today, to January 10th, the number of positive cases in Congo was close to 20,000. And we have to point out that 22 provinces out of 26 were hit, but most of the cases are located in the city or close to the city of Kinshasa. In order to achieve and to be able to do our quick assessment, we started to analyze the impact of COVID-19 on the specific investment portfolio, and we were able to explore some key indicators that are related to the implementation of the family planning activities, use and distribution of family planning, as well as stock ruptures with family planning methods. We have used this mixed approach in order to obtain information directly from beneficiaries. So we have implemented a survey that was presented to the different beneficiaries of the portfolio, and they provided us with qualitative information, data, and we have also provided service data, and we've combined all of these pieces of information and in order to have results that are more comprehensive, that are richer, so that we can actually analyze the effects of the COVID-19 pandemic on the different activities that we are implementing and carrying out. Next, please. So it must be said that we achieved or did several data collection from our partners, and every time we created reports, brief reports that we were able to share with the different governmental teams through the national health program, but also with the different beneficiaries that are part of our investment portfolio of the Bill and Melinda Gates Foundation. And the feedback that we have received is that the beneficiaries actually read these short reports because that helped them to be informed about the impact the pandemic had on the different beneficiaries and to know what the other beneficiaries implemented as measures in order to respond to the COVID-19 situation. But also the program officials used this report for planning measures. So now we're going to talk a little bit about the qualitative results. Next, please. We've had several activities that we were forced to stop because of the pandemic. So all of the activities where we need face-to-face meetings, where we had to be in on the spot in person, those were interrupted during the pandemic. But as I mentioned before, most of these activities were actually were actually relaunched in August. We obviously took into account all the different measures that are required within this COVID environment. There was also some activities that did not stop, but continued to be in place. All of these activities of the program that we could continue to do, we had to do some adjustments. So, for example, all of those activities that we could do virtually, we continue to do those. For example, message communication, data and collection and data analysis, or that were done routinely. We were not able to send the teams on the field to collect the data, but we were also able to do some data collections through virtual platforms, and we could send the data through WhatsApp or through email. So those activities also continued as before. Next. So the beneficiaries that are part of the Gates portfolio adapted in order to try to provide the services despite restrictions, despite difficulties linked to the COVID-19 pandemic. So most of them were able to adapt the implementation of their planned activities in order to achieve the goals for the different programs and projects. We should highlight also that on top of the survey that was implemented, there were two other projects like Global Early Adolescent Survey and the PMA also implemented some surveys in order to understand the impact of COVID-19 on the activity implementation for family planning, especially for young people and adolescents. Now we're going to touch on the quantitative results in order to try to understand the effects of COVID-19 on these results. Next, please. Here we can see that among the partners that we have worked with, that are part of the investment portfolio, some of them provided us with their data, with their routine data. And while we analyzed the data, these are the data provided by DKT. We can see that most of this data is coming from Kinshasa, but the information from DKT belongs to 18 provinces out of the 26 in the country. So DKT, we can observe that there was a drop in indicators for the different methods of family planning. Starting on the month of February, you can see the yellow line where we are in March. So all the indicators dropped until the end of confinement in June, July, and August, when activities started to pick up again and indicators started to increase again. Next, please. the same thing was observed from the information from the project Aqua 3 and gender health. So all these indicators showed that there was a drastic drop starting in the month of March until July, August for all the data regarding distribution and use of family planning methods. But as you can see, if we compare this to all the other graphs, this drop started actually in February until July, August. Next, please. Here we can see the same thing when we compare the data of community distribution. In the community centers, they usually offer the different contraceptive measures, but since that we had the confinement, that we had movement restrictions, we can also see that starting in the month of March, the indicators dropped drastically, and in July, August, the indicators started to increase again when confinement was lifted. Another interesting indicator was to find out about stock ruptures or stock difficulties. So we can see in March, for all the different methods that are offered starting in March, there we have a difficulty with stock because, of course, there was no way for us to organize the logistics in order to provide these family planning methods. So hospitals and health centers were missing stock for all these family planning methods here in Kinshasa. Next slide. Next. Conclusion. Next slide, please. So what can we say in conclusion about the COVID-19 situation? Overall, all the beneficiaries that are part of the investment portfolio adapted quickly and efficiently when the COVID-19 hit the Democratic Republic of Congo. Everybody reacted quickly in order to implement the message of COVID-19 prevention in all of their activities. Most of the difficulties that we had took place between March and May. That was a difficult period of confinement, but all the other activities, we were able to adapt them, and they continued to take place and implemented. We also have to say, before I come to an end, that the activities that we performed, that the goal thereof was to analyze the quick effects compared to COVID-19 on family planning interventions. So we did not do analysis in depth, and we have not really compared the information with the trends of previous year to see if in the long term COVID-19 has had a significant impact on the routine activities. But this is data that we wanted to make quickly available to our partners so that we can know what all the other partners have done in order to adapt to the situation. And because this was a situation that was unheard of before, nobody was prepared for this. So this actually allowed us to get an overview of the situation of COVID-19 and the different activities that were performed. I would like to thank you. If you have any questions, I will be happy to answer. Thank you.
So thank you for the opportunity to speak with you today. I'm pleased to talk about the challenges that have been going on in the US around COVID and SRH, and some hope for opportunities for really improving the situation. Next slide. As I'm sure you're all aware, the US has been particularly hard hit with nearly 400,000 COVID-related deaths thus far and a marked disruption in our social and economic lives. Next slide. It's against this backdrop that today I want to talk about 4 things. First, I will present findings from a survey we conducted in May, early in the pandemic, asking women about their sexual and reproductive health experiences. We use that information to consider what we think will be an upcoming baby bust in the US, and then highlight efforts that providers have taken to reduce sexual and reproductive healthcare barriers. Finally, I will share some priorities for new policy initiatives to improve SRH. Next slide. So let's talk for a second about the SRH context before COVID in the US. Here we have considerable variation across states in the laws governing SRH care and therefore really its availability. Although telehealth certainly existed, there was minimal evidence of its use for contraceptive care or of its effectiveness for this type of service. The US has a contentious environment around abortion, and in many states, there were extensive barriers to accessing abortion even pre-COVID. And the impact of all of this is severe racial and economic disparities in women's sexual and reproductive health and well-being, and their ability to have children if and when they want. Slide 5. So in early May, we interviewed a national sample of women in a rapid response online survey. This early data allowed us a first look at the impact of COVID on women's lives, and we will be returning to the field this spring. The full report is available on the Guttmacher website. Our data show that the COVID-19 pandemic is a public health crisis, but it also dramatically impacts people's most personal and intimate lives. When people are uncertain about the future, they just may not feel like it's the right time to make long-term decisions about having a child. So here in this chart, we show that pregnancy desires plummeted early in the pandemic, as 1 in 3 women reporting wanting to delay or reduce their childbearing specifically because of COVID. And the ripple effects of COVID-19 exacerbated existing inequalities in the US. For example, we found that Black and Hispanic women were more likely than white women to report shifting fertility preferences because of the pandemic. Together, these changes in preferences suggest that we should expect fertility rates to decline. Next slide. So US fertility was already going down before COVID. So think about those fertility rates on a downward hill of a ski slope. And COVID-19 is an avalanche suddenly roaring down that mountain. That downward slope is even likely to get bigger. Now, it takes 9 months to have a baby, of course. So we're just starting to see the first months of COVID-influenced births, but some state data is already showing evidence of declines in fertility. The question is, how big will these declines be and how long will they last? And will there be some subgroups, particularly those who've been able to work from home and are gaining income during this period, for whom fertility might rise? Next slide. The pandemic is also making it harder for people to access the contraception they need to make critical life choices around fertility. In our national survey, 1/3 of women reported problems with access to contraception or other sexual or reproductive health care because of the pandemic. But providers have made many changes to how they are providing SRH services, and I really want to applaud and call out the innovations and resilience of women's healthcare providers. Next slide. So let's first talk about service delivery for contraception. Some of the things that happened during the COVID period include expanded use of telehealth for women who couldn't physically go to their provider, as well as providers starting to provide curbside pickup of supplies or even mail delivery. There was also growth in the use of online suppliers and pharmacies. Some providers shifted to mailing patients self-injectables for depots so they could do this at home themselves. and to promote extended use of LARCs and long-term supply provision like 3-month pill packs. The question for the future is, to what extent will all of these innovations be continued once we go back to, quote, a more normal healthcare and social environment? Next slide. Now let's look at the changes to service delivery around abortion. Early in the pandemic, some states used the pandemic as an opportunity to limit abortion access, and they put into place new restrictions that identified abortion as non-essential healthcare that shouldn't be taking place or could be delayed. These early restrictions generally were either overturned in court or they ran out, and this isn't the environment we're currently in right now. But I think that advocates in the SRH community really saw the need to speak up loudly that abortion is indeed essential healthcare and essential to women's lives and something that cannot be delayed. US providers have shifted to an increased reliance on medication abortion, again, even doing curbside pickup for this service. They've done their best to reduce testing, developing protocols for no-touch and low-touch abortion as allowed in their state. We don't yet know what the impact of this will all be on abortion incidents, and we'll be needing to track this. Next slide. Finally, let's look at changes to service delivery around preventive SRH care, including STIs, because many people couldn't or were too fearful to see their healthcare provider face-to-face. There has been preventive care, whether that's pap smears, mammograms, and in particular for adolescents, HPV vaccinations. It has also meant missed STI screenings and less access to symptomatic testing. In fact, in the US, we've had supply shortages for things like swabs needed for STI tests because of supplies being diverted to COVID testing. Some providers are mailing STI tests to patients for patients to do themselves, as well as doing more presumptive treatment. So the question looking forward is, again, when things get back to normal, will people catch up on this mispreventive care? And what implications will this miscare have for longer term health? Slide 12. As I've mentioned, one way women are getting care has been through increased use of telemedicine. In our national survey, for example, we found that 24% of pill users reported that they had switched to using a telemedicine appointment. Next slide. While the opportunities for telemedicine are great, I think there's a lot of challenges for telehealth for SRH that we're going to need to engage with. This includes trust in the technology, as well as a potential lack of privacy. Think particularly about an adolescent who's home with their parents, or a woman who doesn't want her partner to hear her talking with her provider. Language may be a barrier to using online services, as well as the reality that not everyone has access to either broadband services or a computer for the video telehealth sessions which many insurers have required. And this gets to the legality question. Expansion of telehealth was possible during COVID because states and the federal government changed many coverage and reimbursement laws. Finally, there's a challenge for services that do need to happen in person, like a pap smear. So how do we prioritize who needs to see a healthcare provider in person and for what service? Next slide. As we expand telehealth in the future, there are 3 attributes that I think we really need to be focusing on. Access is one of them, whether through improved technology, improving digital literacy, or expanding insurance coverage. We also should care about quality. How do we make sure that the quality of the telehealth visit is not a lesser good than what an in-person healthcare visit would have been? And cross-cutting both of these attributes is the issue of equity. That is, how do we make sure that people have equitable access to quality care? At scale, telehealth may be cheaper than in-person to provide, and we don't want telehealth to become the poor woman's lesser standard of care. Next slide. As you all know, the United States soon has a new president who is supportive of sexual and reproductive health and rights. So this means that there are many opportunities for new policies. Here I point out just a few. I bring up again the need to support telehealth and to maintain and expand some of the recent policy changes that facilitate it. We also need to work to ensure abortion access, including making medication abortion accessible without an in-person visit. There are opportunities here to really rethink and rebuild our healthcare systems to make them function better. Striking down both the global and the domestic gag rule will help to improve SRH in the United States and abroad. And here in the US, a lack of health insurance remains an issue. And with rising unemployment, there are concerns of women losing their healthcare coverage. So we need greater efforts to build a universal healthcare system that assures care for all. Finally, I think all of this together can help to support and move us towards reducing disparities in access to SRH care and improve outcomes. Next slide. Thanks for your time and listening to this. I've included links here for more information about Guttmacher's work on social media and our website and my own Twitter as well. Thank you.
Hello, everyone. My presentation today focuses on the impact of COVID-19 pandemic on the sexual and reproductive health issues in the Asia-Pacific region. I will also share some interesting program innovations that have been piloted successfully in many countries of the region to overcome the challenges posed by the pandemic. Next slide, please. The ongoing COVID-19 pandemic is posing unprecedented challenges to governments. Health systems are now focused on life-saving measures and critical care, and key health staff have been diverted to focus on COVID-19 response. Community distribution, house-to-house counseling, and satellite sessions have been hampered or just have been discontinued. Many countries have witnessed large-scale movement of populations, with millions of workers having lost their jobs and being compelled to travel back to their homes thousands of miles away, resulting in a confounding socio-economic crisis. Next slide, please. Even within the healthcare facilities, the immediate focus appears to be on life-saving interventions. And family planning services, sexual reproductive health services are being sidelined. This was also documented during the Ebola epidemic in West Africa. Health supply chains are performing at suboptimal levels, with high probability of stockouts of essential sexual and reproductive health commodities. There has been a general decline, global general decline in manufacturing, which has been further complicated by import and export bans and global supply chain disruptions. At the family and individual level, as my colleagues pointed out, lockdowns have resulted in cloistering of couples together and increased the possibility of sexual activity and the resulting unintended pregnancies. Unintended pregnancies because contraceptive availability at home is likely to run out after some time, and procuring additional stocks is difficult. Many couples are now switching to less effective traditional methods, thereby increasing the chances of unintended pregnancies. Next slide. In Bangladesh, the population council study among more than 950 adolescent girls from 3 of the project districts found that 54% of the girls had cuts on health care and medicines in their families. Only 13% of them reported any access to services, including SRH services. In Cambodia, a decline by 20% to 24% has been observed in women seeking sexual and reproductive health services, while in Nepal, we observed 10% decline in short-acting contraceptive methods. The health system anticipates more than 19,000 additional intended pregnancies during 2020. Next slide, please. In Pakistan, a study among more than 200 women from the lowest socioeconomic strata found that the lockdown has forced women to switch from modern to traditional methods due to the non-availability of methods and financial constraints. And also, as we found out earlier, the pandemic has resulted in food insecurity. One of the women pointed out, Corona will not kill us, but hunger surely will. Something to really ponder upon. In Indonesia, more than 900 private practicing midwives have closed their services, their practices, due to lack of protection, PPEs, personal protection equipments, and many of them have died because of infection. The National Family Planning Board, BKKBN in Indonesia, estimates 370 to 500,000 additional unintended pregnancies during 2020. Next slide, please. This is a slide from our partner organization IPPF, which had analyzed data from March to May in 2020. And as you can see, all throughout their clinics in many countries and many districts, there has been a reduction from 40 to 80% across the board in all services related to sexual and reproductive health and their utilization. Next slide, please. The impact on family planning, as we pointed out just now, has been at various levels. At the central warehouse level, there have been stockouts due to problems in manufacturing, global supplies, supply chains. The same thing has happened at the lower levels because of shifting priorities and failures to supply contraceptives. Couples have switched to less effective traditional methods, increasing chances of unintended pregnancies. And then all of a sudden, in some countries, there has been a surprise of a change in method mix. People who were relying on IUDs or who wanted to go for terminal methods or permanent methods are not able to do so because they are being asked not to come to health centers because of the fear of contracting the infection from health workers, other patients, or from surfaces in the hospitals. As a result, there has been a surge in demand for emergency contraception and abortion in many places. Next slide, please. The UNFPA Asia Pacific Regional Office prepared a model on the possible impact of the COVID-19 pandemic on general sexual and reproductive health issues. What we did was we purposely selected 14 countries from the region, and these countries are Afghanistan, Bangladesh, Bhutan, Cambodia, India, Indonesia, Laos, Myanmar, Nepal, Pakistan, Papua New Guinea, Philippines, Solomon Islands, and Timor-Leste. And as you can see, the study modeled a best case and worst case scenario of COVID-19's impact on family planning and maternal mortality. The model, we had a best case scenario where there could be a decrease of 20%, a worst case scenario where there could be a decrease of 50% in the coverage of access to contraception. That could lead to a large number of unintended pregnancies. In the year 2020 and 2021 alone, as per the model, there could be an increase between 11.4 to 20.7 million additional unintended pregnancies in the region compared to the baseline that was achieved in 2019. So we can see this has really affected, the pandemic has really affected the health system and sexual reproductive health in the region. The combined effects of COVID-19 pandemic on the availability of short-term modern contraception would mean that the unmet need for family planning could spike in 2020, increasing by 21% to 40% on an average compared to the projected value since 2019. In the worst case scenario, this would entail reaching a peak of 26% of women with unmet need for family planning. Next slide, please. As we saw earlier, the pandemic has had a clear impact on maternal health and on the health-seeking behavior among pregnant women. More women are now avoiding antenatal visits and opting for delivering at home because of the fear of contracting the infection from health workers or from hospital services. This is likely to result in increased maternal and neonatal mortality and morbidities such as obstetric fistula, which is common in some countries of the region. Quality and availability of essential sexual reproductive health services has been adversely affected, including basic and comprehensive emergency obstetric and newborn care and skilled attendance at birth. The maternal health workforce is not well protected, and adequate personal preventive measures such as PPEs are not available for everyone. Next slide, please. As you can see, this slide would show that there could be an increase in average maternal mortality rate across the 14 countries in the region that we had modeled, and because it is anticipated that the skill attendance at birth and the institutional deliveries could drop by 20 to 50%, the best and worst case scenarios. In 2020 alone, the maternal mortality rate in these 14 countries could have seen a 17 to 43% increase. respectively, for the best and worst case scenarios, reaching 214 per 100,000 live births per year to 260 per 100,000 live births per year, compared to the projected baseline of just 184 per 100,000 live births in 2019. Next slide, please. Now we come to what happens when countries are facing such a pandemic. Many countries, many governments have come up with innovative ideas how to address the issues, how to address the challenges. I'll take the example of Papua New Guinea, where in order to improve access to contraception in underserved and remote areas where the government presence was limited, the government decided, as per the advice from UNFPA, decided to loan contraceptives to a private NGO. And that private NGO, because it was based there, this is something, it was a unique experiment in Papua New Guinea, where a private NGO received contraceptives on loan from the government and distributed them in a very far-flung remote area. And it was a very successful experiment. And the government plans to partner with this institution in the future as well. Many countries introduced telephone helplines and hotlines with 24-hour services throughout the week, including in Bangladesh, India, Pakistan, Philippines, and also these provide data regarding the availability of services, the availability of facilities where contraceptives could be available, and also answer frequently asked questions. Mongolia had an ongoing telemedicine project for safe motherhood, which has now been expanded to include family planning. In Myanmar, the government decided to partner, the Ministry of Health decided to partner with other ministries like the Ministry of Internal Defense, Ministry of Forestry and Agriculture to transport contraceptives from the central level to the provinces. And then in India, we had an SMS-based logistic information system that could, where a health worker, even in a village, could send the data on the availability of stocks to the central level. This has been now expanded to the lowest level, and also the government of India came up with training e-modules for all levels of health workers during the pandemic. Then also, as I mentioned earlier, in Bangladesh, teachers and community mentors came together to help adolescent girls on sexual health issues by home-based phone lines, not mobiles, household phone lines, where in groups of threes, these teachers and mentors counseled girls about menstrual hygiene, about reproductive and sexual health. Next slide, please. Similarly, in Laos, the government decided to partner with UNFPA to undertake an analysis of the distribution and consumption patterns of contraceptives in the first three months or the first quarter of the year, so that we could focus the government's attention on how the use has gone down and how the government needs to increase its support, its focus on family planning. In Cambodia, the government, along with partners, developed social media messages that have been very popular and that have been used by adolescents and adults alike. Similarly, in Pakistan, the government decided to support national socio-economic impact assessment, and that was the reason why we came to know that many women were talking about hunger and talking about non-access to contraceptives. And finally, in Indonesia, the government undertook an assessment of COVID-19 impact on the sexual reproductive health services, including the socio-economic impact of COVID-19. Finally, Indonesia, the government of Indonesia partnered with many organizations, including UNFPA, to promote partnerships with faith-based organizations and religious organizations to make sure that COVID-19 does not disrupt a successful family planning program in the country. Next slide, please. Finally, just to conclude, I would like to add some conclusions or suggestions based on our observations. As we have seen, unmet need for family planning is likely to spike or go higher in the coming years. And in the worst case scenario, it could reach a peak of 36% of women with unmet need. The government or the policy planners need to ensure comprehensive sexual and reproductive health service provision as a part of essential services, including family planning. They need to provide adequate protection for service providers. We need to have a greater domestic investment in health system strengthening and improving availability and access. We talk about universal health coverage and universal health care. The idea of improving availability through helplines and counseling is always welcome. And similarly, the ideas of innovations of e-modules and telemedicines can be learned from these countries. Finally, no governments can reach everyone. We need partnerships. We need to expand partnerships, not just with traditional players and traditional partners, but also with individual private practitioners who are working, including private practitioners of traditional medicines who are working in remote areas. And these private service providers and even private drug shops and private pharmacies have been helpful in many countries. Partnerships with other ministries and departments and encouraging innovations need to be promoted and encouraged. Thank you very much.
Thank you very much to all our presenters. And now we're going to open it up for questions. So please take a moment and post your questions on the Q&A. And I will address them and ask our presenters to respond. So I'm going to start with a few questions that are already posted. And we'll start with Beth Kangwana, and I see two questions relate to contraceptive use in Kenya, and one relates to what was the contraceptive landscape and some of the changes in contraceptive use before the pandemic, and can you talk a little bit about the types of methods that are usually used in Kenya, the method mixed?
Thank you for those questions. So from our data, what we did see is there was likely to have been a decrease in contraceptive use after the mitigation, the COVID-19 mitigation measures were implemented. And we can allude to this because there was a decrease in people going to health facilities to access contraceptives, mainly because people were scared to access the health facilities because of COVID. We also saw in our qualitative studies that there was poor supplies of family planning methods. So, some of the respondents said that they'd go in and they couldn't find the contraceptive that they used to use, or there was no contraceptive at all. We also saw that, the pandemic decreased access to financial resources. A lot of people lost their jobs. And what we saw was that, and you saw in some of the comments, that people would rather use the little money they have on food rather than on healthcare services. So I guess all of this is alluding to the fact that it's likely that contraceptive use was low due to access. In terms of what types of contraceptives were being used, we saw that adolescents were mainly likely to use injectables compared to pills. Pills were very low in use, but I don't think that trend is any different to what we saw before COVID happened. So that would be my input to those questions. I don't know if Karen, my colleague, might have something to add to that.
Thanks. No, just one interesting thing that also was in the data is that actually, in particular around adolescents, is that because of all the lockdown measures, they were less likely to be spending time with their partners, and I think that might change some of their motivations for spending limited resources on family planning. Thanks.
Thanks, and I think there are lots of interest in your data. So one of the questions is, have you published this data, or do you have any plans to do so?
So the data itself is available on the Population Council website. We are in the process of publishing some of the data in journals. And we are still trying to sift through the qualitative findings. So the quantitative data is available at the Population Council website, and the qualitative data is soon coming out.
Thanks. And I'll ask just a last insider question about, I know you're about to collect a second round of data, and what kinds of questions and what are you hoping to find out with the second round of data collection?
I shall maybe hand that question over to Karen, who is the PI. Over to you, Karen.
Sure. So we actually just started data collection today on a second round of data collection. If Beth and I are looking a little bit tired, that's why. So now that we're almost a year into the pandemic, we'll be looking, I think in particular, looking at issues of pregnancy, school re-enrollment, and child marriage. So some of those longer term outcomes that I think might not have shown up immediately or within at least the first 3-4 months of the pandemic.
Thanks very much. And now I will turn to Jean Lambert. Jean Lambert, il y a quelques questions qui portent sur, bien sûr, les déclins des services de santé et la distribution communautaire de planning familial. Et donc, un des commentaires, c'est pourquoi est-ce que ce déclin a commencé dès février? Et question supplémentaire, est-ce qu'il y a d'autres facteurs qui peuvent aussi contribuer à ces déclins au moment des restrictions?
Yes, thank you very much for this question. Indeed, we were surprised ourselves to see that most of the data showed that the decline had started in February, well before the start of COVID and lockdown. But that also made us curious how that curve behaved in previous years. So we haven't had the time yet to make a comparative analysis with the curves of previous years, because as I said in my presentation, one of our objectives, it was to quickly distribute to our partners in the investment portfolio of the Bill and Melinda Gates portfolio, the immediate effects on their activities, and especially how each one of the partners was reacting to this new situation in order to maintain enough activity in the field and share quickly with other partners what the ones and the others would do, because we can always learn from each other and adapt our own activities. So regularly, after every 2 months, we would collect new data to update the measures which had been set in place and how the activities were led, what had stopped, what had been adapted in order to continue to be furnished and provided as a service. And so we shared this question with the people who asked us why the data started going down in February. And probably, and this, I don't have the scientific data to prove this, but that's my idea, is that it's the time right after the end of year celebrations. Maybe there are some preoccupations for procuring contraceptives at the beginning of the year. It could be because of that, but it could also be that the COVID came to add up to a situation that was already declining. So it's not impossible, but we will keep analyzing to try to understand globally how to explain this curve, comparing it with the curves of the previous years. Thank you so much.
Dr. Sharma, I know you need to join a new session. We have one comment for you. Thank you for excellent presentation. Could you say a bit more about how the high and low estimates projections of unmet need were determined in your model?
Thank you very much. A number of issues were taken into consideration when we conducted that study of the model. It was based on the baseline of how much was the unmet need, what was the contraceptive prevalence rate for modern contraceptives, the health systems status in the country. For example, Afghanistan would be different from what is in India. And then also we projected what would happen if a certain number of people could not reach those facilities or the facilities were not functional. There are a number of parameters that were taken into consideration, and from that we arrived on two scenarios: the best case scenario when the impact would be less, and the worst case scenario when the impact would affect the system, the health workers, the availability, and the access. So these were a number of parameters that was taken into consideration in the model. Thank you.
Thank you very much. And now I want to travel from sub-Saharan Africa to the US. And this is a question for you, Laura. Some PMA data in several sub-Saharan African countries found that women's desire to have a child has increased slightly, or actually didn't decline. So do you think the difference in the US results reflects differential impact of COVID in US versus some other types of settings? And based on historical responses to crisis, do you think fertility desires in the US will rebound?
Thank you for that question. And the PMA data certainly sounds interesting. I mean, I think we are going to see variability across settings, just as we've seen variability in responses. Even within the US, the difference between where you lived and how extensive the lockdown was, whether schools were closed, whether you continued to go to work or not, has been great. And that certainly is going to have an impact on people's feelings about fertility. If you've been a parent at home with 1 or 2 toddlers during this time period, I don't know how excited you are about the thought of planning another child right now. Whereas older women who haven't had a first birth, maybe they're not going to wait because time is ticking, and they're the people who are most likely to be able to work from home, continue to have the same salary. Their investments have been going well. So I think we are going to see a lot of heterogeneity in these impacts over time. How long will it last in the US? I think remains unclear. I mean, yes, we're going to have a return to normal, but our normal was a declining fertility rate. So separating out that trend from this impact over the long term, we may never really know, or we will leave that to econometricians to try to parse out in fancy models.
Thank you. And I think we are just on the hour. So just a round of applause to all our presenters. There are many other questions in the chat box, so I hope we'll have a chance to read your publications and globally contribute to this very unsettling and ongoing epidemic as well as economic crisis, and find innovative solutions to address them in the months to come. Thank you very much.
Thank you.
shooting stars with the power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Everyone will always be here to sing.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We on the ground in every area. We're the ones to make a world a better place. We want the best, we want the way. And there's something for a future so bright.
Because our bodies and the future we holding. We want for you to see that everybody can win. Could it be education or contraception? Cause the boys we always be fine.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice.
We gon' climb up and then rise up. Won't keep our eyes shut, we ain't got enough. I know you tired of seeing things the same way, but in time you realize that things change. We the demographic dividend. You see the work that we putting in. I'ma stay true to me and use my opportunity to show you how to build a community with unity.
உன் வாழ்வு உந்தன் கையில், எதிர்காலம் உன் கண் முன்னில். மனதையும் உடலையும் பாதுகாப்பார். வேண்டும் வேண்டாம் என்று சொல்ல உனக்கு மட்டும் உரிமை உண்டு. தேவையில்லா குழப்பம் நீக்க வெவ்வேறு பல வழிகளும் உண்டு. உதவக்கரங்கள் உண்டு, முன் வந்து சொல்வாய் என்று. உதவக்கரங்கள் உண்டு, நீ முன் வந்து சொல்வாய் இன்று என்று. இன்றே முடிவு செய், உடல் நலத்தை உயர்த்தி வை. இன்றே முடிவு செய், உடல் நலத்தை நீயும் உயர்த்தி வை.
Because our bodies and the future we hold. We want for you to see that everybody can win. Could it be education or contraception?